Let me talk about a question with the class. I heard Olivia was telling you that y'all were talking over the lunch break.
Just three of us.
No, it's actually a good question or a good comment about which is more important, the diastolic or the systolic, because we've obviously got guidelines that address both of them. In that she had heard and others have heard that diastolic is a more important number, that you have to really pay attention to that. Well, I said you have to pay attention to both of them, and what I told her is that, diastolic, the folks who are the diastolic advocates are looking at that bottom number because that's the pressure that the system is constantly exposed to. That's the rest number, that's the bottom, what you're going to see. And when you look at cardiac cycle, the systolic part is only going to be about a third plus of the whole cycle. So if you have a really high systolic reading, it doesn't always stay there. You get some rest from that number. But that bottom number is the constant pressure in the system. Well, it depends. Okay, so the people who advocate diastolic are paying a lot of attention to that. What's the constant pressure in the system? But you do have to look at context. Let's say if you have an older person, who had a fairly high systolic reading, even though their diastolic reading was good, that can be a fairly wide pulse pressure, and that can be an indicator of significant atherosclerosis. For example, somebody has a reading of 160 over 88. Okay, they're below 90, so if you're a diastolic person, you're saying, well, that's actually controlled, and we don't want to make too much noise off that top number, so we might do a little bit of lifestyle and maybe a little bit of diuretic to get it down, but we're mostly okay. Well, I'll look at that thing and think, I've got 170 over 88, that's a 92 millimeter mercury pulse pressure. That's a fairly significant sign for advanced atherosclerosis, because if they're sitting there at a fairly good baseline, and when their heart pumps, it goes up this far, how compliant do you think that person's arteries are? Not very compliant, because when a heart pumps, blood vessels tend to expand out. As that volume comes out of the heart, they kind of open up like this so that keeps the pressure down. When you have very, very atherosclerotic blood vessels, they're sitting here, the heart pumps, and it just all becomes pressure because they don't open up, they're just fibrotic. Those are the ones that are likely to pop, rupture, cause stroke. So you really have to pay attention to both numbers and bring those numbers into range to minimize risk for events, either cardiac or cerebrovascular. It's not a bad comment. I've heard it in my life too. There was a time when diastolic was the basis of guidelines, and so it may go all the way back to that. We always looked at the diastolic figure. Now they focus on both diastolic and systolic, and they've been doing that for 35, 40 years. So we just know more about the risk of the numbers, and that's why you have guidelines that address both. Okay? Not a bad question or thought. Okay, let's go ahead and look at the next part of this. This is going to be the drug phase. We're going to go through the drugs and look at them. You've had some of these, and some of them you have not. But let me talk to you about how to think about drugs. I have really stripped this down a bunch. There are so many antihypertensive agents, lots of names. It's very mystifying, and it can be very intimidating. And I don't want you to be intimidated. There's going to be a little bit of it just because I've got to get some names on the table so you know some stuff, but I don't want it to be too painful. So the way we do it is we usually give some representatives. Don't fall out on me. Was that you? Who was the one sneezing? It was you. Okay. Go back one more row. You'll be okay. Okay. Any conjunctions become another mortality figure in the PA program? That's terrible. But the way you need to think about medications, and I think this is true when you're first starting out, and this will be true as you move on through, there will always be a lot of different agents in a variety of categories. So you want to get familiar with at least one agent, representative agent in a group. And if you know that one well, that will serve you for the most part. You will have to change from time to time with individual patients, but for working knowledge, this is a good way to go about it. And within the class, there's several things you can look at. Within the ACE inhibitor class, there's lots of different drugs. So do they vary? Yes. Do they vary significantly? They can. Is it important? Not always, but sometimes it is. So that doesn't really help you. What do I need to know to get by? But the things that do differ between these drugs, they do differ in onset of action, so some work faster than others. Some last longer than others. That's usually indicated by dosing intervals, once-a-day drugs versus 2 or 3 time a day drugs. Dosing intervals are affected by that duration of action. The adverse effect profile varies between drugs within a class. So even if you know a member, there may be some that have an adverse effect a whole lot less likely than others, and that might be important for treatment sometimes. And then cost can also vary from pennies a month to hundreds of dollars a month. It's pretty shocking, the cost differentials. Okay, so what do I want you to know for these medications? And at this point, it really gets down to what do I need to know for the test, because you've got limited time and you got a lot of stuff to cover and you got a test coming. And I don't want you to go freaking out over stuff. So I'm trying to get it down to what you do need to know. I was a student once, I do remember this, and I used to hate it when they just walk in there. We used to know everything, it was everything. They just throw you everything, you just kind of walk out. Well, that's less than helpful when you can do some things to kind of get it weaned down to here's where you need to operate right now, okay? So the things I want you to know, I do want you to know mechanism of action, just basically where is it working, how does it work? I don't need dissertations, but I do want you to know what it does. Does it work in the brain? Does it work in the periphery? Does it work on the heart? What is it doing? Okay? Daily dosing range, I am not going to ask you to memorize daily dosing ranges. I'm not going to ask you to remember dosing ranges for anything. Now, if I want to do something with the dosing range in question, I will give it to you so that you can work with that. Is this starting dose or final dose? But I don't need your brain cells eaten up with that now. You can find it when you need it, and if I need it for a test purposes, in terms of titrations and evaluations, I will give it to you. Okay? Thank you for the gift. So thank you. That's the best I can do for y'all right now. Okay. But the other thing I want you to know about the daily dosing range is that the dosing ranges that are given here are the dosing ranges advocated by the JNC8 to treat high blood pressure. These medicines can be used to treat a lot of different conditions, and dosing ranges vary for the condition. So the ranges I have put in your handout materials are the JNC8 ranges for blood pressure. And that will look different than what you see in the manufacturer's handout. So when you start Googling stuff, you have to be very careful to look for the indication and the dosing range for that indication, because they are not the same dosing ranges for everything. And there's implications. No need to use a higher dose than the upper limit for the condition, because the higher you go with the dose of a medication, what happens? The greater the risk of what? Side effects. Yeah, and there's no need to do that. Dosing frequency, I'm not going to ask you to know that for this test. I will not ask you the dosing range. I will not ask you the frequency. That's two things out. So you do have to know the mechanism of action. You do have to know common adverse effects, and you do have to know how to monitor it. And we're going to talk about the big ones as we kind of go through here. The other thing you have to know is the learning objective, but I think it's almost intuitive that you have to know this. You need to know, I'm not going to ask you to know generic and trade names. I'll give you both at the same time, okay? But for your own sake, you probably need to memorize the generic name of the drugs I give you in the category. ACE inhibitor, this lisinopril is an ACE inhibitor. You need to know that. You can't not know stuff like that. So that you're going to have to memorize coming out. But I'm not going to ask you to give me the frequency or the dosing range or anything like that. So that'll take a lot of that little brain space and give it back to you, because that stuff can eat your brain up, okay, before a test. And I think Dr. Vanessa has done enough. He's done enough to eat up your brain space. I'm going to give you a little bit back. Okay, so let's go through here and look at some of these things. Okay, now we already talked about this earlier, that the JNC8 advocates medications from one of the following classifications in non-black people. Black people, it was thiazides and calcium channel blockers. And here, it's going to be in African Americans, thiazide and calcium channel blocker, but for everyone else, thiazides, ACE inhibitors, ARBs, angiotensin receptor blockers, and calcium channel blockers. So let's just look at those categories in detail and give you the examples that I want you to hold on to. The first group is the thiazide type diuretics. There's two agents I'm going to ask you to know. Chlorthalidone, remember that from your reading. The woman who had the medicine in the purse and didn't tell the truth about it, it was chlorthalidone. Very commonly used in Oklahoma, and then hydrochlorothiazide, also known as HCTZ. Those are very commonly used drugs. You kind of need to know them. Okay, they're thiazide type diuretics. Their mechanism of action is interesting. They lower blood pressure by diuresis, just getting volume out of the system. And everybody always thinks that diuretics keep blood pressure down by taking volume out of the system. Long term, that is not the case at all. Long term, your volume comes back to the normal level. It's not constantly taking volume out, but what it does do, I mean, you'll pee, but you retain that fluid back. What they do is they actually mobilize salt, sodium and water from arterial walls, which helps them relax and not be as tight. So what they're doing is moving salt and water out of arterial walls, reducing the tone, or they directly relax the vascular smooth muscle by a mechanism that we really don't quite understand. So they're relaxing vascular tone in the end. It's not taking fluid out of the pipes, it's just making it relax and get bigger, okay, in the end. Okay, the daily dosing range, I give it to you. I'm just going to tell you a little tiddly-wink about this. Really, you need to operate between 12.5 and 25 milligrams, and that's what you will see in most combination products when they're put together like that. You don't really need to go higher than 25. In the dark ages, and with a lot of the side effects you see, when you're operating at 50 a day, and they used to use HCTC 50 a day, 50 twice a day, 100 milligrams, those big doses were the side effect doses. When you operate down in 12.5 to 25, your risk of any of the side effects is way reduced, and that's why it stays there. And you don't reduce blood pressure more by blowing the dose out from the roof. When you're to 25, you've forgotten about what you're going to get. You want to keep pushing doses, you're pushing doses for some other reason, to diurese them more, but not to lower blood pressure more. Frequency, it's a once or twice a day drug. Common adverse effects, short-term increase in cholesterol and glucose. I don't really care if you remember that at all. You can put an X or if you want to say brain space. I do need you to know that they decrease potassium, sodium, chloride, and magnesium. They do. If you lower magnesium, what cardiac phenomenon is possible? Dysrhythmias, just broadly and generally dysrhythmias. You get a patient in the ER with a new onset arrhythmia that you don't know anything about, you're going to be checking, potassium, you're going to be checking calcium, and you're going to be checking magnesium. And if those are all normal, then at least you don't have an electrolyte issue, most likely. Okay? So you do have to know that. They also increase levels of uric acid and calcium. What, let me ask you, what disease is most linked to uric acid levels in the blood?
Gout.
Thank you. So if you have a patient with gout, are you going to be choosing a thiazide as your first agent? Probably not. You're probably not going to go that way because you got other things you can choose, right? Okay? So be careful about that, but that's one to remember. How do you monitor a thiazide type diuretic? All of these you go monitor with blood pressure. It's kind of a duh. You do have to follow up blood pressure. It kind of makes some sense. But a Chem 7 will get a lot of stuff on these drugs because Chem 7, are y'all familiar with that?
No.
Y'all had Chem 7s? Okay. Guess y'all hadn't read it yet. That's just a very limited set of readings. You get a sodium, a potassium, a chloride, and a CO2, so it's kind of helping you assess those in the electrolytes in the body. BUN, glucose, and creatinine is usually what you get, so they have to evaluate renal function and metabolic status from an electrolyte standpoint. So that is a very good one to remember for diuretics. Uric acid, if they have gout, calcium, and then magnesium if they have a dysrhythmia. Easy to remember, right? Yes, okay. Another one, ACE inhibitors. You've heard about those for a while. The representative example we'll give you is lisinopril. It comes generically, but it's also Prenavil and Zestril. Just ACTs and chlorthalidone, they'll be generic. They're like a penny a month plus dispensing fee. They're just dirt cheap. Okay. Lisinopril, another common use agent. What does it do? Now, Dr. McNeil went over renin-angiotensin aldosterone, correct? What they do is they very specifically block the angiotensin converting enzyme, and that results in reduced levels of angiotensin II, which is a vasoconstrictor, okay, so that would elevate blood pressure, and it reduces the levels of aldosterone, and we've already been over aldosterone. That causes salt and water retention at the nephron level. So if you block the enzyme, you end up with lower levels of angiotensin II and aldosterone, and you can lower blood pressure. Okay. It's just a picture for fun. Okay. You've seen what it does. I'm not going to just go all in detail again because you've already had your pathophysiology about that. Are there any questions about that? I don't want to just blow past you if you're not comfortable. Okay, y'all okay with that for now? Or the answer is you will be on Monday. Okay, gotcha. All right. Okay, ACE inhibitor, the dosing range I got down here. Let me go back before. Okay, dosing range is given dosing. They're mostly once-a-day medications. The adverse effects are important to remember because they are common and they cause problems. Cough can occur in up to 25% of people and maybe even more than that. The cough is distinctive because it is a dry, non-productive cough. You're not harking something up. You're just coughing and nothing is coming up. I have had it. I take Losartan. My blood pressure is right on the line, and I decided to choose to treat as opposed to not. I could have made a case either way. I decided I wanted to live. I want to inherit all the insurance money when Dr. Lopez gets knocked out. She's working. I'm telling you, you work more dead than alive, so you better be watching out when you're sleeping over there. Don't tell her. I told you, this is between us.
You're on camera.
I am. Now, if anything, I will be taking that film. If anything happens, I don't need y'all talking. Yeah, I'm going to, well, I'll share. She's that woman enough money to make it work forever. I got $1 million beat for yourself. Okay. All right. But the cough can happen, and it is a dry, ongoing cough. It becomes very annoying, nothing you can do, and you have to stop the medication. There's some things I could talk to you about, but they're hardly worth the energy. You just move on to other agents. So that's a very common one. They did a study. One of the biggest workups for chest x-rays and all kinds of invasive procedures for lung disease is an ACE inhibitor cough. If you get a dry, non-productive, ongoing cough that is bothersome, and they're on an ACE inhibitor, stop it. That's the first thing you do. It's dirt cheap to do. You can figure out something else out. If it's still around after you pull that medicine off for a week or two, then you may have something else to look at. But don't waste the money until you pull that off. Hyperkalemia is another one. If ACE inhibitors can cause serum potassium to rise, it goes back to the aldosterone thing. If aldosterone causes sodium retention, water retention, and potassium going away, and an ACE inhibitor knocks out that aldosterone, then potassium can stay in there more often, and it can actually rise. So you can get some problems there. These medicines can, so you're always wanting to monitor potassium, they can cause renal insufficiency in selected people, particularly diabetics. They can cause angioedema, another common adverse, well, it's not common, it's uncommon, but it's notable. In fact, in Good Shepherd Clinic last week, a woman came in who had angioneurotic edema, and it was, they thought at one point that she was ACE inhibitor reduced, but she has had it beyond discontinuation, so she probably just has idiopathic angioedema. But the way it presents is this. They will end up with, they can have a swollen tongue. They can end up with swelling, periorbital swelling around their eyes. They can end up with laryngoedema. It just swells up the larynx, and they actually feel like they'll choke. So this is an ER thing. People go to the ER choking out. And it will happen after about the first dose or two. It's not one of those things where you have to go and go and go and then you have it. If you're going to have it, you're going to have it, and they are going to be panicking about it because they feel like they're going to die. And the truth is, if they don't go somewhere and it's really bad, they can die. So angioedema is important. It is more common in African American patients, far more common. And the lady that we saw actually was the African American lady. Okay? So you need to know those. Cough, angioedema, hyperkalemia. Rash can happen. Loss of taste can happen. It actually creates like a metallic taste. More common with captopril than lisinopril, but it's out there. And they are contraindicated in pregnancy. They are teratogenic. So you will not have a pregnant woman on an ACE inhibitor. If you do, and something happens to that fetus, you can be in trouble. It usually gets picked up by somebody somewhere in the system, but it's not something you want to do. Okay. Monitoring, blood pressure, Chem 7 because of potassium. Okay. Questioning about the adverse effects, the rash, the other issues that get the cough, and then just physical assessment. ARBs, angiotensin II receptor blockers. The agent of choice to memorize is losartan. Also, it comes generically. Cozar was one of the brand names for that agent. It directly blocks the actions of angiotensin II, which is a vasoconstrictor. ACE inhibitors wipe out aldosterone and angiotensin II. ARBs block the angiotensin II directly. They don't do anything, to that. They're not blocking the actions of aldosterone. They block the actions of angiotensin II, but they do stimulate release of aldosterone, so they can block that. Okay, when they block angiotensin II activities. The results of those, you end up with reduced arterial tone and lower blood pressure. Okay, dosing range 50 to 100 once or twice a day. Adverse effects can be hyperkalemia and renal insufficiency, and they're contraindicated in pregnancy too. So these ACEs and ARBs, side effect profile is kind of similar. So you see you got the potassium issue, the renal insufficiency in the pregnancy. You do not have the cough issue. Okay? You do not have the angioedema issue. So it's a difference. Monitoring with blood pressure and Chem 7. Calcium channel blockers. Have y'all talked about those yet? They probably should have come up in dysrhythmias. And have y'all just had bits and pieces of coronary artery disease? Y'all had ACS, so y'all probably talked about it. All right. There are two groups of calcium channel blockers, and all calcium channel blockers are not the same, and you kind of have to remember them in these categories. This will be the big way to sort them out, because they pharmacologically have exaggerated differences in the way they work, and you need to think of them like that when you think about them. So the first thing you think about is non-dihydropyridines versus dihydropyridines. I know that sounds terrible, but I don't know any other way to sort them out because there isn't any other word I can use to kind of describe them. Those words are based on the chemical structure. Some have a dihydropyridine structure and some are non-dihydropyridines. Okay, so here's how you sort them out. I'm giving you two non-dihydropyridines, verapamil and diltiazem, which you have probably heard of. They're both generic. I'm giving you long-acting, the generic K-Lan, isopten for verapamil, cardizem, Dilacort, Tiazac. But if you remember verapamil and diltiazem, I'll be ecstatic as examples of non-dihydropyridines. And then the dihydropyridine is amlodipine, also known as Norvasc. Y'all may have heard of nifedipine, Procardia. There's some other ipines. All the ipines are dihydropyridines. The ipines are idines. All right. That's probably pretty good on tape. I'll have to figure that out. Okay. but most of them end in that that DIPINE, the dipine or ipine. Those are dihydropyridines. Kind of weird. So that's the groups. Now let's look at what makes them different. Mechanism of action for the non-dihydropyridines, that's your verapamil and your diltiazem. They're calcium channel blockers, so obviously they're blocking calcium channels, which are in the cardiac tissue, and they're also in the vascular, the arteriolar smooth muscle tissue. They inhibit the influx of calcium into the smooth muscle cells of peripheral vasculature, leading to relaxation and reduced vascular tone. Okay, now I know when Robin Paul taught you about smooth muscles somewhere way back when, you know that there's calcium that flows in that's important for contractile functions. Remember actin and myosin cross-linking, and they kind of ratchet together to make the muscle tighten up. Well, you have to have calcium for all that stuff to work. No calcium, it doesn't work. So these block the flow of calcium in, so they cause the smooth muscle to relax. If you relax an arterial or smooth muscle, it's going to relax out and get bigger, and the blood pressure is going to go down. Okay. The other thing these drugs do is they also slow heart rate and reduce the force of myocardial contraction. So they slow down contractility and the force of myocardial contraction. Have y'all been given that word yet? I don't know that you have. Have you heard of inotropy? Okay, y'all heard of chronotropy, inotropy, and dromotropy. Okay, well, y'all are operating big. Okay, that's good. So what these do is they slow down heart rate. So verapamil and diltiazem, somebody walks in with a heart rate of 40, and they have always been 70 and 80, and you started those for blood pressure, you better be thinking the medication is wiping out their SA node, or you'll be missing a big one. They also operate on the AV node, so they can not only slow heart rate, they can slow down conduction through the AV node as well. And they reduce force of contraction, inotropy. Okay. Mechanism for the dihydropyridines, this is the amlodipine, the ipines, is same as above. They inhibit that flow of calcium into the smooth muscle cells, but these are the most potent peripheral vasodilators in all the calcium channel blocker family. So if you looked at verapamil and diltiazem, their ability to slow down calcium in peripheral arteries, and you looked at amlodipine, and I asked you which one of those does that the best, you better tell me amlodipine. They are just significant vasodilators. They will put you in the floor. They are that good at just dropping pressure down. They do not slow heart rate or affect myocardial contractility to the same degree. So when you think about dihydropyridines, you think about big peripheral vasodilation with the heart slowing and contractility to a much lesser degree, very much lesser degree. When you think of verapamil and diltiazem, you think slowed heart rate, slowed contractility, and effects on peripheral arteries, but not to the same magnitude. So you kind of lean with the non-dihydropyridines lean into the heart effects more, and with the dihydropyridines lean more to periphery, okay, with what they're doing. If you can think like that, you will be thinking right. Nice picture, nice calcium. Okay. Here's the ages. These are just the dosing ranges. Most of them are once or twice daily medications in the long-acting form. Amlodipine, Norvasc, the dihydropyridine is a once a day, and that's what you'll see for most people, which makes it convenient. What do? Let's look at the non-dihydropyridines. They obviously can affect cardiac conduction, and if you slow it too much in somebody who's already got diseased conduction system, then you can end up with pathology, or aggravation of pathology. So they slow cardiac conduction. They can worsen systolic function and heart failure. If that heart muscle is not pumping real well, or it's been blown out by a lot of CAD, then you put this drug on top of that, really shuts it down even more. Okay. Verapamil is notorious for constipation. I mean, notorious. Old person on verapamil, I will guarantee you they will come back and tell him they haven't used the restroom in 2 or 3 days. It just shuts it down. Pretty significant. Monitoring blood pressure. EKG, and questions about adverse effects. This is a category of drugs where you need baseline EKGs before you throw on somebody. Somewhere in the system you have to know that conduction's okay and that they don't have baseline bradycardia or baseline AV block or something like that. Okay, adverse effects of dihydropyridines. This is amlodipine. This is pretty interesting and pretty significant too. They can cause ankle edema, and it's also one of those rule-out things. You'll see a person that'll come in, they'll have ankle edema, and you're thinking, oh, they got heart failure, something's really bad going on. Nope, it's a very local effect of that drug, and you can actually pull it off and see it go away. And you may have to kind of move drugs around, but you don't want to get led down the path of a whole new disease to work up when you just started neurovascular and complain about ankle edema. It may be that. Flushing is pretty significant. They just flush red because it's such a powerful vasodilator. And headache. Any vasodilator is going to cause headache. If you vasodilate cerebral vasculature, headache. Okay, pounding headaches. So ankle edema, flushing, and headache. You monitor with blood pressure, question about adverse effects, and do physical assessment. And that's it. Other antihypertensives. Now there's a whole bunch of other drugs that we're just going to look at, and I'm going to try to give you high points because I don't want your brain killed off. I really, really need you to know those 4 big categories. That I can guarantee I'll ask questions on test about that. These I'll highlight the big stuff I want you to know, and I'm not going to get too crazy about this other category of drugs, even though they are important. They're not unimportant, but I've got to use your brain for the big stuff. Kind of blocks. Okay, if the patient's blood pressure cannot be controlled on 3 drugs from the recommended groups, the thiazides, ACEs, ARBs, or calcium channel blockers, and remembering that it is inappropriate to use an ACE and an ARB together, then it may be necessary to select a 4th medication from another class or use a specialist. But we're going to look at some other classes. The other classes that we have there are other diuretics. There are aldosterone receptor blockers. There are adrenergic inhibitors. There are alpha-1 blockers. There are beta blockers. There are combined alpha-beta blockers, and there are direct vasodilators. Oh, there's a lot of stuff. Lots of drugs. Okay, let's just look at some of these things. The loop diuretics, this is a very important agent. I know you have had to have heard about it somewhere before now. Furosemide, Lasix. It's almost always generic. It's similar to mechanism of action of HCTZ. You've got a dose usually twice a day. The adverse effects are the same as HCTZ except they lower calcium, which I already talked about earlier. HCTZ raises serum calcium, furosemide lowers serum calcium. It's a distinction you do need to keep in your mind. So since these have electrolyte issues, the monitoring is going to be blood pressure and Chem 7. There's a group of agents called potassium-sparing diuretics. And they are used because you're trying to, since HCTZ gets rid of potassium, they came up with this group that doesn't get rid of potassium, and they're very often used in combination with the thiazide. They are not very good blood pressure lowering drugs, but they are good at keeping the potassium up, so sometimes they combine them with hydrochlorothiazide so that you get blood pressure lowering without losing potassium. Okay, so that's the trick of it all. I've got doses on here. The common adverse effect of a potassium-sparing diuretic is very obvious, hyperkalemia. If they can keep potassium up, if you are particularly responsive or you dose too high, then you really get a lot of potassium. So it ought to be easy to remember that a potassium-sparing diuretic can cause hyperkalemia. If anybody tells me a potassium-sparing diuretic causes hypokalemia, I will hurt you. Really hurt you, okay? Dr. Latassi will be spared from the insurance fraud scheme that I'll get you. It's not going to happen. Okay, monitor blood pressure at Chem 7. I'm not going to worry about this picture, but the potassium-sparing diuretics do tend to, this shows you where they work. The potassium-sparing agents work at the far part of the distal tube and even in the collecting tubule. So you see where they're operating up here. Thiazol's proximal part of the distal collecting tubule back here. The loop diuretics like Lasix works in here. Lasix works in there. Thiazol's work in this little piece of the distal tubule. Potassium-sparing diuretics work here and down. And there you go. There are agents called aldosterone receptor blockers. You'll hear about these in heart failure. Spironolactone is a common agent. Have y'all talked about that yet? Dr. Britton may have thrown that one out when you did renin-angiotensin aldosterone, because you kind of talk about what's normal and what operates against it. Well, this one, aldosterone, these drugs bind to aldosterone receptors and keep aldosterone from doing what it does. So, if aldosterone holds on to sodium and water and exchanges that sodium for potassium, then if you block that, potassium stays in and sodium and water go out. So they get rid of, water and salt, but you can get hyperkalemic. Okay, so it's another one of those hyperkalemic agents. Okay, just a picture. No need to worry with that one. The doses I've given you here, they're usually once a day. The adverse effects notable, hyperkalemia, and you have to remember they can cause gynecomastia in male patients. And I'm not joking, and it's not uncommon, it's very common, and it will be the major problem for a patient. If you have a male patient, you're starting on aldosterone blockers, and you do not tell them that they can have increase in breast tissue, they will be upset. And it's notable. I've seen men, it's just like, my gosh, it's amazing how much, tissue development can happen. But it can happen. So gynecomastia, it may impact compliance, but you have to tell people going into it. Usually when you're forced in aldosterone, it's a life-saving agent in heart failure, and it really is something you need to work with. And people will usually play ball if you're talking about heart, if you're talking about life-saving. You monitor blood pressure, EQM7. Another group are the adrenergic inhibitors. These are older drugs, and you will see them sometimes in rural Oklahoma, and you'll see these in older people in nursing homes sometimes if they haven't been pulled off yet. But the classic agent is reserpine, usually generic. Has anybody seen or heard of reserpine in practice anywhere? You will not see it much anymore. But I'll tell you what, it absolutely is an effective drug. I had a patient I saw at the VA one time, could not get his blood pressure controlled. I had him actually refer to me, and they said, can you work through this medication, figure out what to do, and read his regimen. So he actually had adverse effects all over the place for almost everything he could use, and lots of complaints. And he was placed on reserpine, and his blood pressure went to normal, and it stayed down. I mean, it was amazing. It's the way the drug works. It depletes norepinephrine from those postsynaptic terminals, so when they're going across to put the heat on the arterial structure and stimulate it, it stops those catecholamines from being released, and it just depletes those little storage vesicles, and you really have very little to stimulate the blood vessel level. So they're very effective. So here's the picture of that. Here's the presynaptic nerve fiber. You've got all the production of the catecholamine inside. They are placed into little bags. When the electrical activity comes along, the little bag moves to the periphery, and it opens and releases its contents across the synapse. Well, reserpine depletes the filling of these bags, and so there's no catecholamine to make the nerve work. Okay, so blood pressure goes down. Dosing range very small. Adverse effects are limiting at bigger doses. At lower doses, they're probably not too bad. But they can cause nasal congestion, sedation, and depression was the big reason why they were actually pulled away from common use in a lot of people, because they can cause depression. All of these problems are when the drug was used at doses far beyond what are recommended now. But it scared off practitioners. oh, I can't use that. And actually, I'll reserve them way over here in situations where other agents cannot be used or tolerated. They also can activate peptic ulcer disease, but that's very uncommon at the doses recommended now. So monitoring is just blood pressure and asking questions about adverse effects. Okay, here's an agent that gets used for lots of stuff. Clonidine, catapress, it's used a lot in addiction medicine because it has a role. Have y'all heard of clonidine before? Catapress, it's out there. It's available as a tablet. It's also available as a patch. You don't see it used too much more that way. But clonidine stimulates alpha-2 receptors in the brain stem, which leads to decreased sympathetic outflow from the vasomotor center, which causes a reduced arterial tone and lower blood pressure. So you all know the vasomotor center controls respiration, vascular tone, heart rate. Remember? The medulla oblongata is there. That's why when you have strokes, brainstem strokes, blood pressure goes haywire, breathing is erratic, and they're almost uniformly fatal because you killed all the regulatory center for the vital functions. Okay, move on. These drugs have significant adverse effects, even the doses are recommended. I've given you a range, it's twice a day. Sedation is big, over 50% of people get sedation. Dry mouth is big, over 50%. If somebody's on this and talks about having a dry mouth, I guarantee it's a drug. I tell people up front, here's what's likely going to happen to you, and then we deal with it. Lethargy, bradycardia. I have seen patients referred into cardiology who've been on clonidine. They've been referred in for pacemakers because they feel like their SA node's blown out. And what has happened is they've been placed on clonidine at a pretty good dose. It's doing what it's supposed to do. They do not have a dysrhythmia. They do not have a pacing issue. They have a clonidine issue. And so it's very easy for the cardiologist to make big bucks by just saying DC clonidine, heal, they're just cured, because that is not appreciated how significant that impact is on a person's origination of that impulse. The other issue with clonidine that is probably the bigger one to worry about taking care of patients, you have to warn, it causes a withdrawal rebound hypertension. So if they're on clonidine and they decide not to refill next month after they've been well controlled and they've been operating pretty good, then they decide, I don't want to use it, or their practitioner decides, I'm just going to stop it because they're too sleepy and got too much dry mouth, and they just stop it cold turkey, their blood pressure will come back higher than it was when they started treatment. It is possible for a person to have a stroke or heart attack from withdrawal, rebound, hypertension from stopping it. So they must be warned when they started that they should never miss doses. If you need to pull it off, it has to be tapered off. Now you can cut the dose in half for a week or two, cut the dose in half for a week or two, and then gradually, eke it on off. Okay, it can mess up thinking and cognition in older people. Yeah.
I heard that clonidine also ups the effect of your narcotics.
It can do that. Okay. Yes, it can.
So if that's a thing.
So in the street, when people are going around raking the medicine cabinets and they find clonidine, that one's got some cash value. You can kind of stick that along with some other things that kind of hype you up, or they're trying to smooth you out, and just there's so many combinations out there. It's amazing. I think actually medicine cabinets of people with lots of medicines are treasure chests for the people who like to adventure with drugs and try things out. And it's amazing. I mean, everybody knows about Soma. Soma is a big expense. When I worked in the VA, people used to like to get their medicines at a fairly low copayment and then sell them back in the street for major cash money. So their benefit as a veteran was the medication, but the double benefit was the cash return if you wanted to sell it, which of course is a federal crime, but that didn't stop some people from doing stuff. So if you're a veteran and you're running low in money, you just have to get certain stuff that you don't like, and people would do that. I'm serious, it's kind of sad and dangerous. Okay. So you're monitoring with these as blood pressure and EKG because the impact on impulse generation and transmission is significant. In question about adverse effects. Okay, now here's a big drug that will come in very important later. Have y'all talked about alpha-1 blockers yet? Okay, let me just give you this is just very intro stuff. It will come in later in urology. It's a prostate drug. It can be used for prostate issues in male patients. But the agent to remember is doxazosin, Cardura. It works by blocking alpha-1 receptors on arterioles. And what does the alpha-1 receptor do? If you stimulate an alpha-1 receptor on an arteriole, what happens? It's a vasoconstrictor. So if you block that, what's it going to do? Relax it. Okay, goes the other direction. So these are alpha-1 blockers, relax the arteriolar tone, so they're used that way. They're usually once-a-day drugs for the most part. Okay, we don't need to see if that's just, you know what alpha-1s are. Adverse effects are notable. Postural hypotension is major league with these, especially after the first dose in the elderly and in diabetic patients because they already have impaired autonomic function. Okay, so an alpha-1 blocker is significant for hypotension, and more notably in older people or people with diabetes and autonomic dysfunction. They'll have that. It is so notable after the first dose that you have to counsel people about that. If you don't counsel people about it, they can end up with bad things happening to them. And I have my patient story is true. I had a patient that came in one time who had been started on the alpha blocker, and he had not been told about it. And in fact, they told him to take it at night, which to me was even more problematic. It was being told to be taken at night because they felt like they'll miss the first dose hypotension, but they'll just be asleep. And then after that first dose, it becomes a little bit less of an issue, but it's always really an issue. It's just real pronounced after that first dose. This person took it at bedtime, and of course he was an older male, and he had to get to go to the bathroom because he had prostate problems. So he gets up out of the bed half dazed and asleep, and he is orthostatic. So he gets up and he faints, and he falls over, and he hits the bedside table, and he hit his head, and he hit his head near his temple, and he was like about an inch off from hitting it to the place where he could have killed himself, you know, in the room. So he comes in the clinic after he'd been given this alpha-1 blocker agent. I'll talk about what happened. Is like everybody was like, okay, folks, look at this. So from that point forward, always tell people, be careful, you'll be okay. When you first start using it, I like them to use it in the daytime, be fully awake. When you get up out of a chair, stand up and just hold on to the chair for about a minute, get your bearings, be sure you're all okay, and then you can go walking on. When you get out of bed, get up, sit up, hang your feet over the edge for about 30 seconds, stand up, wait about 30 seconds, see how everything is feeling, and then go on. Because if you don't tell people, they are going to fall. And we've already talked about fall risk with hypotensive agents. So that's important, and that's notable. So wasn't that bad? You got up in the middle of the night and crashed over and almost died for treatment of hypertension. Would have been a bad end. Okay. His monitoring is just blood pressure and asking questions about hypotension. Beta blockers, I am not going to do a lot with these because I think Dr. Latesi told me she had covered these with you all. Didn't y'all talk about beta blockers? Okay. Let me just tell you what I need you to know. We'll just be very cursory about this. Did she talk to you about cardioselective versus non-specific?
Yes.
Okay, good for her. She gets a positive reward there. Okay. The cardioselective agent I want you to remember is the tenolol, and I'm sure y'all talked about that. I'm not even going to go over, I'm going to let it go. But beta blockers for hypertension work centrally. They're central agents. They work to decrease outflow, and they also reduce run and release. There's beta receptor control of run and release. So they have an effect there. Okay. Okay. I'm going to do it. Okay. Let that go. Propranolol is the non-specific beta blocker. So you understand there's beta-1 specific is more unique for those. beta non-specific cover both beta 1 and beta 2 receptors. Did she make for you the distinction that a beta 1 selective at higher doses loses some of the selectivity? Okay, let me just repeat that again. Propranolol blocks beta 1 and beta 2 indiscriminately, just does its thing. The higher the dose, the more block they get. In beta 1 specific, at the lower doses, they tend to be fairly specific for beta 1 receptors. As you push to higher level doses, you begin to get some beta 2 blockade. They're not clean beta 1 specific. So lower mid-range doses, more likely that you're just working with beta 1 receptors. When you start moving up to maximum doses, you start seeing some beta 2. So that's just as a distinction. Okay, adverse effects I am not going to cover with y'all because I know she's talked about those with you all. I promise I won't even ask one on this test. And if she asks, it'll be a Dr. Latassi beta blocker question. I'm not going to ask it. I've just given you some of what they are and the receptors that are involved, but let's just let that be done. Combined alpha beta blockers, I need you to know the name of this product because it will also be used in cardiology, in heart failure. Carvedilol, Coreg is usually generic. That is an alpha 1 and a beta 1 blocker. So it does both things. The mechanism is what they do singularly. And the biggest adverse effect from carvedilol is hypotension. Big time, be careful. Direct vasodilators. There are a few agents that just very directly stimulate the vasculature to just relax. And the one I'm giving you is minoxidil, also generic, it's also called Melanotan. It is notable because it causes hair growth. Over the counter you can get minoxidil, Melanotan, for hair growth in men they used to use it for male pattern baldness, but honestly male pattern baldness cannot be defeated outside of a hair transplant. What it might do is slow it down. The way it usually shows up, this minoxidil, is some significant undesirable hair growth. Okay? It can happen in women. I've had women who were on this drug back in the day, and they take it and end up with darker black hair on their arms. Okay, that's kind of a shutdown side effect for some people. It can happen in men, but it tends not to be that problematic because they already have more hair to begin with, and so there's hair growth. Most men will tell me it's making hair grow, but not where I need it. So it's like it's not really what it's supposed to do, but it will do that. But it's used for that benefit. It's as a direct vasodilator. It does all the things you expect vasodilators to do: orthostatic hypotension, headaches, fluid retention, and tachycardia are compensatory. Anytime your blood pressure crashes low, what is your body going to try to do? It's going to try to save itself. Okay, so when blood pressure is low, it tries to save itself. So how does it try to get blood pressure up? Very naturally. Using increased heart rate, so you start tacking away, and you turn on the renin-angiotensin-aldosterone system and pull salt and water back into the system. So if your pipes are so big that your volume is not enough to keep the pressure at a certain level, then what you do is you circulate that blood faster, you try to get the pressure up, and you also suck more water and salt back into the system. So anything that vasodilates powerfully is going to cause a tachycardia, cause some fluid retention, and headache, orthostasis. So they all kind of go hand in hand. Then hirsutism is that little unexpected side effect. In fact, they were using it for cardiovascular events when they discovered the hair issue and decided to try to angle it for some other uses in the population that might like that. Okay, we are going to officially stop. Give yourself 10 minutes, and then what we're going to do is talk about cases. A lot of different ways to think about using the drugs. And I apologize, I am so sorry. This is just that part where you have to just kind of dump it. Okay, now we're going to talk about it. Have fun. You'll be more fun. I promise.